Mycobacterium tuberculosis সমস্ত কিছু আমরা আজকে ডিসকাস করব। ওকে, হোয়াট কাইন্ড অফ ডিজিজ ইজ টিউবারকুলোসিস বলো তো? ইজ ইট আ ইনফেক্টিভ সিন্ড্রোম? ইজ ইট আ chronic disease? Is it a granulomatous disease? What kind of disease it is? Granulomatous infection. So Mycobacterium causes granulomatous infection mostly and primarily in the lungs. ঠিক আছে, লাংস হচ্ছে ওদের প্রাইমারি সাইট অফ ইনফেকশন, বাট লাংস ছাড়াও অনেক জায়গায় ইনফেকশন করে, উই উইল সি। তো দ্য পেশেন্ট কামস টু ইউ ইন দ্য ওপিডি with very peculiar and cardinal symptoms like chronic dry cough. Chronic বহুদিন ধরে হয়, এটা না যে আমরা রোববার দিন আইসক্রিম খেয়েছিলাম, গলা ব্যথা ঠান্ডা লেগেছে, and the patient comes to you in the OPD with cough and expectoration for last 2 to 3 days, and you give a sputum for ZN stain. That is not advisable and that is not recommended. Okay, these kind of patients will come to you with a chronic cough of lasting more than 3 weeks or 2 weeks, or even more than that, sometimes even months, with very little or no expectoration. So mostly it will be dry. And the patient may also present with the symptom of hemoptysis. Hemoptysis means blood with sputum. Okay. And the patient might also come to you with weight loss, recent weight loss, okay, and occasional fever. So prodromal symptoms will be there, but mainly the cardinal symptoms will be hemoptysis, dry cough, and weight loss. So you have to suspect TB in this kind of patients. So we'll come to the disease. So we'll come to the organism first. কোন কোন অর্গানিজম করছে? মাইকোব্যাকটেরিয়া ইজ আ আমব্রেলা অফ অর্গানিজম, তার মধ্যে অনেকগুলো স্পিসিস আছে, ঠিক আছে। তো ইট ওয়াজ ফার্স্ট ডিসকভার্ড বাই রবার্ট কক when he isolated in 1882. So it is not a very new disease, it's a pretty old disease. And the classification, if you see, mycobacteria can be classified into 3 categories. One causes primarily tuberculosis, which is called MTB complex. One causes leprosy, which is called Mycobacterium leprae, and one causes a different set of infections which are called Non-Tuberculous Mycobacteria. Okay, they sometimes mimic tuberculosis, but mostly they will cause cutaneous infections. They can cause lung infection, but they will be causing primarily cutaneous infection. So we will be discussing MTB and NTM today. So why they are called mycobacteria? Myco কথাটার মানে কি? Why myco? Any idea why it is called mycobacterium? Mycobacterium মানে কি বলো? Myco মানে কি? MYCO. What does it mean? They have mycolic acid in the cell wall. You are partly correct, but it is not only that they have mycolic acid, they are called mycobacteria. The thing is, the term myco means fungus. ঠিক আছে? Mycobacteria resembles fungi. কি করে হলো? এটা তো ব্যাকটেরিয়া, then how come it is resembling a fungus? Because whenever the mycobacteria are in cluster or are in a place where they are getting infection, they are arranged peculiarly like a mycelium of a fungus. Mycelium মানে কি? A group of hyphae or agglomeration or collection of hyphae is called mycelium, and they have a very waxy cell wall similar to a fungus. That is why it is called mycobacterium. Myco means it is resembling a fungus. Mycobacterium tuberculosis complex, which causes TB, is composed of these 5 species. তার মধ্যে কে কে আছে? First হচ্ছে Mycobacterium tuberculosis, then you have Mycobacterium bovis, Africanum, then you have Microti and Capri. These are 5 organisms which are the member of Mycobacterium TB complex. Okay, these all the things causes MTB. Now coming to the cellular architecture, if you see and if you compare it with the gram negative cell wall, আচ্ছা বইতে কিন্তু লেখা থাকবে যে Mycobacteria is weakly gram positive. Weakly gram positive. But I would say do not mention it as gram stainable, because we don't see mycobacteria in the gram stain. We don't see. Okay. So it's better if you don't write anything pertaining to the gram stain. If you are asked what kind of stain mycobacteria is done, you will simply write acid fast stain or Zn stain, Ziel-Nielsen stain. Do not write it is weakly gram stain and all these things. Boite lekha thake, but in the slides you won't find MTB so much visible in the gram stain. So these are the cellular architecture. Niche theke jao, this is a cell membrane which is the same. Then you have something called as lipoarabinomannan. So that is a layer. That is a layer which helps these bacteria survive the phagocytic action of the phagocytes in our body. Okay. So lipoarabinomannan is kind of a virulence factor to these organisms. Then you have peptidoglycan. Peptidoglycan is a part of which cell wall? Gram positive or gram negative? Which cell wall contains peptidoglycan? Gram positive? Okay. Gram negative thake na? Okay, so peptidoglycan is still here. Now these three things are very new to you. First thing is a arabinogalactan. Arabinogalactan is a protein which gives them a structural support so that they maintain their bacilli-like structure. Then you have mycolic acid. Mycolic acid is the thing which is responsible for acid fastness. Acid fast মানে কি? Acid fast মানে হচ্ছে the organism is resistant to decolorization by dilute mineral acid. If you give the organism a stain, for example, if you give the organism carbolfuchsin, which will give them a red colored stain, and then you give the organism some dilute mineral acid like H2SO4, like HCl, dilute. Okay. So they will be resistant. They will not be decolorized. Okay. So that is why it is called acid fast. And this mycolic acid is responsible for the acid fastness of the organism. And you have mycosites, which is again some structural support, and it also helps in the acid fastness of the organism. Now this thing, the mycolic acid layer, it will be responsible for the drug resistance, and also it will be responsible for the waxiness of the mycobacterium. Now we will come directly to the risk factor and pathogenesis, how the thing is transmitted. Everybody knows that MTB is transmitted by respiratory particles, which are known as airborne particles. So whenever we are coughing, we are sneezing, we are releasing droplets, and we are releasing some very micro particles which are smaller than droplets, which are called airborne particles. So this mycobacteria will be transmitted by airborne route. Apart from the respiratory transmission, they can also be transmitted with ingestion, kichu kheye nilam, and with inoculation. Jodi amar skin er upore lage with abraded mucosa, then also I can have a cutaneous infection. Now you tell me one example where if I ingest something, I can develop TB. Ki khele TB hote pare? Person's sputum. No, he is already infected by TB. If he swallows his own sputum, he will not be infected again. He is already infected. Why will you have somebody else's sputum? That is the grossest thing I have heard. Yes. Okay. Yeah, so that is the answer. So if you drink unpasteurized milk, then you can have TB, not by unpasteurized sputum. Sit down. Okay. So see, যে বাড়িতে দেখবে মিল্ক প্যাকেটগুলো আছে, মিল্ক প্যাকেটে গায়ে লিখবে লেখা থাকে প্যাস্চুরাইজড মিল্ক. ওকে, প্যাস্চুরাইজেশন ইজ আ প্রসেস ওয়্যার ইউ ক্যান কিল দ্য মাইকোব্যাকটেরিয়াম বোভিস. ঠিক আছে. So that is how you get rid of mycobacteria from the milk. Okay. So ingestion, inoculation, and primarily by respiratory infection or respiratory airborne particles, aerosols. Okay. Now what is the risk factor? সবার কি হয়ে যাবে? Yes, সবারই হবে. Nobody is immune to TB. There are few people who are mostly under high risk. কারা কারা? বলো দেখি. Anything you have to put under high risk, put HIV. অলওয়েজ ইন হাই রিস্ক, সেটা মাইকোব্যাকটেরিয়াম হোক, সেটা স্ট্যাফাইলোকক্কাস হোক, সেটা ক্লেপশেলা হোক, এভরিথিং এইচআইভি. So HIV takes down the cellular immunity. Hence, people living with HIV, that is PLHIV, that those persons are under high risk for Mycobacterium tuberculosis. Okay? আর কারা কারা আছে যারা কিনা খুব কম বয়স, অ্যাডোলেসেন্ট, ইনফ্যান্টস, এবং যারা কিনা খুব এক্সট্রিমস অফ দ্য এজ. ওকে, সো দিজ আর দ্য পিপল হু আর ইন দ্য হাই রিস্ক ফর দ্য টিবি. এছাড়াও দেখো কি বলছে, ওভারক্রাউডিং. সো ইট ইজ আ ডিজিজ where if you have adequate ventilation in the room, then the transmission is less. If you don't have adequate ventilation, একটা রুমের মধ্যে 5 জন করে রয়েছে, কি 6 জন করে রয়েছে, কি 10 জন করে রয়েছে, in those cases, in the camps, okay, in the camps, in the slums, so all these places you can have a tuberculosis. So what are the kind of tuberculosis? These are the broad kind. তার মধ্যে primary kind is pulmonary tuberculosis, which is 60 to 90% of the TB are pulmonary TB. এছাড়াও কি কি হবে দেখো, extra pulmonary TB. Anywhere in the body outside lungs, it is EPTB or extra pulmonary TB. কোথায় কোথায় হতে পারে? Everywhere you can think of. It can go to the lymph node, it can go to the pleura. In fact, pleura is the covering of the lung. So if the TB is affecting pleura, not the lung, it is again extra pulmonary because it is just outside the lung. Okay, so it can go to pleura, it can go to upper airway, it can go to the genitourinary system, it can go to the bone marrow, the skeletal structure, and the most common thing that the TB gives is the Pott's spine. See, Pott's spine or the Pott's disease. Skeletal spine, you have the tuberculosis in the bone. That is what it is called, the Pott's spine. It can go to CNS, very common. TB meningitis, right? TB meningitis is very common. You can have GI TB, pericardial TB, and cutaneous TB. So all these places TB can occur, but mostly it is the disease of the lungs. There is something called miliary TB. Miliary TB means when the bacilli is spreading through the blood, it can get lodged to various organs, and it can have a different kind of extra appearance in the lungs. Those extra appearance in the lungs is very common in HIV patient, and that is called miliary tuberculosis. Okay, it is just a part of PTB. Now primary and secondary infection মানে কি হচ্ছে? Primary মানে আমার ইনফেকশনটা প্রথমে হয়েছে. The first infection occurs to the patient is in the lungs. So what happens is, in the lungs you have something, the infective site is called the Gons focus. Okay, but in the secondary tuberculosis, যেখানে কিনা endogenous reactivation হয়েছে কিংবা exogenous secondary infection হয়েছে, সেখানে the primary site is called the Siemens focus. এবং Siemens focus এ যদি caseation থাকে, সেখানে আমরা বলবো Asman's focus. So these are the three things you have to know. One is the Gons focus. Gons focus means the lesion formed at the initial side of the lung is called the Gons focus, and mostly tuberculosis is present in the apical portion of the lung, apex, okay, the apex, because in that part of the lung you have the highest oxygen concentration, and this is completely aerobic organism. That is why it is mostly affecting the apex of the lungs. Okay, so lab diagnosis, I have already told you the symptoms. Now coming to the lab diagnosis, so what will be the specimen? Respiratory specimen ki ache? Sputum. If the patient is unable to give sputum, then what will you do? You do a bronchoalveolar lavage. So you give a bowel fluid for TB PCR, you give a bowel fluid for Gene Expert, you give a bowel fluid for ZN stain. Okay, so it depends on what kind of specimen you are handling, but mostly in the OPD cases we do collect sputum. Now the thing is, how many sputum? Previously, when it was RNTCP, they suggested that we need to collect 3 samples. 3 samples, day 1, day 2 and day 3. Now 3 samples is not there. We only have to collect 2 samples. Still now people are sending 3 samples. The old people, the old doctors, they want to send 3 samples. Fine, no problem with it, but we generally suggest that 2 samples is recommended now. One is the spot sample. The patient came to you in the OPD, you tell the patient, rinse your mouth with normal water and then give a sample. If you don't rinse your mouth, what happens is epithelial cell comes, gram-positive organism comes. So that will contaminate the specimen. So you give the same day sample and then you tell the patient, you come to the next morning and you give the morning after sample. Okay. If the patient is living far apart from your clinic, then you tell the patient, you come to me again after 1 hour of giving the sample and then give another sample. পেশেন্ট যদি পরের দিন না আসতে পারে তাহলে 1 ঘন্টার গ্যাপে আরেকটা স্যাম্পল নেওয়া যেতে পারে, বাট ইউ হ্যাভ টু গিভ 2 স্যাম্পলস. ওকে, the collection is very important because the area where the patient is collected, it should not be in front of you because you are having a chamber. সেই চেম্বারে যদি পেশেন্ট এসে কাশতে থাকে, so the chamber will be contaminated with aerosols of MTB and the next patient or you will be infected. So it should be a closed room but well ventilated, exhausted. Then you should have a sputum collection vial which is screw capped. It should not be open vial. The patient and name ID number like, then you can send the sample to the lab. In case of extra pulmonary TB, whether it is a cutaneous, whether it is a bone, whether it's a tissue, you have to send the samples to the lab যেখানে collection হবে. For example, if you have a abscess, you can give pus. If you have a tissue or a bone, you can give the tissue itself. So it depends on which site the infection is happening. Now you see the sputum sample is subjected, or whatever the sample, you have subjected the thing to the Zn stain or Ziehl-Neelsen stain. Zn stain তোমাদের আগে নিশ্চয়ই পড়ানো হয়েছে, হচ্ছে তো? The first thing is the primary dye is the carbamazepine, concentrated carbamazepine. You have to heat the dye so that the dye gets incorporated into the cellular architecture. Then you keep it and then you wash it again. Then what is the decolorizer? Dilute mineral acid. Dilute mineral acid, 20% or 25% of H2SO4. Or you can use acid alcohol also. Acid alcohol is also used. Okay. Then you again wash and then you put a counter dye or a counter stain, which in this case is methylene blue. So the background of the slide, the cells in the slide, the epithelial cell, the polymorphonuclear cell, they appear blue color, and the bacilli, they will appear red color. So they will be like this, slightly curved, beaded appearance, beaded. It is not uniformly stained, it is beaded. Therefore, bead lagje na. So this beaded appearance is because of the mycolic acid. So uniform staining doesn't occur in the cell wall. Partial staining occurs. That is why it gives rise to a beaded. There is no actual beads in the bacilli. Only thing is that the distribution of mycolic acid, they give rise to a partial staining. So that is why continuity of the cellular the cell wall is not maintained. That is why it is a beaded appearance. And you then put the slide under the microscope and you see these kind of things. Now, the RNTCP has been replaced by something known as NTEP. RNTCP was Revised National Tuberculosis Control Program. Okay, RNTCP. Now RNTCP doesn't exist. It is being replaced by NTEP. NTEP means National Tuberculosis Elimination Program. Revised National Tuberculosis Control Program. Okay, sit. Now NTEP is being formed, replacing the RNTCP. So wherever you find RNTCP, replace it with NTEP. So we give this kind of report. Acid fast bacilli seen 3+. তুমি যদি নাই জানো 3+ মানে কি, how do you interpret the Zn stain report? Whenever you are putting the stain under the microscope, if you find greater than 10 bacilli in one field, in oil immersion field, Okay, that is 3 plus. If you find 1 to 10 bacilli, suppose দুটো করে আছে কি তিনটে করে আছে কি পাঁচটা করে আছে এক একটা ফিল্ডে, then you have 2 plus. If you have 10 to 99 bacilli in 100 oil immersion field, okay, then you give 1 plus. If you find 1 to 10 bacilli per 100 oil immersion field, then you give scanty. And whenever you are giving scanty report, the number of bacilli found in the 100 oil immersion field must be mentioned. For example, scanty bacilli found, bracketed, 3 bacilli found per 100 oil immersion field. That is the report. Okay? বুঝেছো এটা? Quantification of acid fast bacilli. Now coming to the lab diagnosis again, you do a ZN stain, you see, you give the report, and then you have culture. Culture, there are two methods. One is a liquid culture, one is a solid culture. Okay? Solid culture, we are still using this media which is called LJ media, Lowenstein-Jensen media. Okay? LJ media is greenish colored media which contains a pigment called malachite green, which is again a low selective media which inhibits gram positive organism. Okay? So this media is greenish colored media. A media tate you inoculate the specimen, you keep it for at least 4 weeks, 4 to 6 weeks. The tuberculosis causing mycobacteria, it grows like this, ektu holud colony hoy. So we call it rough, tough and buff colony. Rough means the surface of the colony is rough. Okay? Tough means whenever you try to pick the colony, it is very hard, it is very not fragile. Okay? And buff is the color. So it is kind of a yellowish tinged colony which signifies Mycobacterium tuberculosis. Okay? And then you have something called as automated liquid culture. Liquid culture kintu we use something known as Middlebrook 7H9. So that is the media. If you are asked what are the media of Mycobacterium, you should first say LJ media, which is solid culture media. Second, you should say Middlebrook 7H9. Don't say blood agar and all these things. Blood agar amra culture kori na. Okay? Middlebrook 7H9, that is the liquid culture media. Dile liquid culture media te, then you put the liquid culture tube in the backtech machine or in the automated machine, and then if it is positive, the machine flags positive and you do a ZN stain and report. That's all. Now coming to the identification, what are the identification methods apart from ZN stain and this culture? We do not use serology. There is no antigen testing. There is no antibody testing because WHO has told us you do not test antibody for these patients or antigen for the MTB. So MTB kintu kono rapid card nei. Previously we used to have MPT64 antigen. At antigen chilo, ekhono hoyto ache kichu kichu jagay MPT64 antigen was only antigen that was tested in the immunochromatography, but we currently do not use. What we use is molecular method. It is the fastest and it is the most productive thing that you can do. You put a MTB PCR in the lab. Why? First thing is that you have a confirmed report. You don't have to wait for 6 weeks to get a report. 6 সপ্তাহ ধরে patient মরে। You get this MTB PCR report in 2 hours. If you test with a gene expert or a TrueNat, you get the report in 2 hours. Sputum now, cartridge ভরো, machine ভরে দাও, machine print report দিয়ে দেবে। That's it. Okay? So, and another thing is, this gene expert or TrueNat, whatever you use, we also get a drug resistant gene, and the drug is rifampicin. So rifampicin resistance is also given by the machine. So if it is a rifampicin resistant, you get a rifampicin resistant report. You start the alternate therapy. Now you talk about sensitivity. এরকম রিপোর্ট তোমরা অনেক পাবে যে ZN stain এ no acid fast bacilli seen, but PCR এ MTB detected. How? ZN stain দেখতে পেলেন না কেন? Because the sensitivity of ZN stain is low. That is exactly what you should get inside your head right now, because you don't have to have a confusion later. TB detection by PCR, the sensitivity is, you see, 95%, 95% to 88% TB. And the limit of detection is 16 bacilli per ml. So, in 1 ml of sputum, if there are 16 bacilli, TB will give you positive. I mean, TB PCR will give you positive. But in ZN stain, there has to be 10,000 bacilli per ml. Then only you will get a positive in ZN stain. You understand the difference between 16 and 10,000. It is huge. Generally, what we see in the practical daily labs is whenever the TB detection is around medium or high, we get a positive in ZN stain. But whenever the TB detection in PCR is low, very low or scanty, ZN stain will be negative. So, do not rely 100% on the ZN stain if the patient is symptomatic, given for a PCR or a gene spot. Yes, they are a little bit costly than ZN stain, obviously because of the machine and the reagents. Then you have line probe assay. Line probe assay is used mostly for the drug testing. So this is the algorithm. You will find this in the book, but it is not so simplified in the book. I have simplified this a little bit. Jekono case you have a smear examination. If it is positive or if it is negative and you still have a suspicion the patient might have TB, you subject it to CB-NAT or a TB PCR, whatever it is. And then if it is positive for MTB, you start off with the drugs. If it is again negative, you give for culture and wait for the report if the patient is not symptomatic. If the patient is symptomatic, then you can clinically diagnose TB without having evidence of lab. You can have a radiological evidence, lab negative ashe, radiology positive ashe, and I suspect it, highly suspected of TB, you can start off with the treatment if the pulmonologist wants. Okay, so that is clinically diagnosed TB if the suspicion is very, very high. But mostly you get something from the labs. You get a positive report from the labs. So what is latent tuberculosis? Latent tuberculosis means the disease is latent. You don't have an active symptom, but you have parameters or markers that suggest it's a TB. ধরো কোথাও একটা রেট্রোপেরিটোনিয়ালে কোথাও একটা টিবি হয়ে বসে রয়েছে, you are not able to diagnose it. Okay, so you diagnose it in the indirect method. You cannot diagnose it with a direct method. তুমি antigen তো নেই, you cannot have a PCR, you cannot have a ZN stain, all are negative, but you still suspect it's a TB. You go in for two method testing. One, it is called tuberculin skin test, and another one is called IGRA. IGRA means immunoglobulin release assay. Okay, interferon gamma release assay. IFN, gamma release assay, we call this TB gold bol at testing assay. It's a ELISA based testing where you put the patient sample to a challenge where they will release some interferon gamma which will be captured by the reader and which will give color and will interpret with the OD value. So that is how we release or we do the IGRA testing. And tuberculin skin test is very simple. You call the patient, you give something known as antigen which is a PPD23 antigen, purified protein derivative. So that is the antigen. You give 1 TU of PPD into the flexor surface of the forearm, and then you tell the patient ki ekhane saban lagabe na, tel lagabe na kore, you tell the patient to come back within 48 hours, 40 to 72 hours. Ashar pore ki dekhbe, you will find some induration is happening on the testing site. ঠিক আছে, তো you measure the induration কতটা আছে you measure. If it is more than 10 millimeter of induration, then it is a positive report. That means the patient has an exposure to the TB. That doesn't mean the patient has TB. The patient has exposure to the TB. That means there is specific antibodies that are there. সে হয়তো আগে টিবি হয়ে গেছে, হতেই পারে, বা হয়তো আন্ডারলাইং টিবি চলছে, you cannot diagnose. তাই জন্যই we do the passive testing. Now, if it is positive for this is called Mantoux testing. Okay, if it is positive for the Mantoux test, you take the call, you check the radiology and you can start the treatment. If it is a pediatric patient, যদি বাচ্চা হয় তাহলে কিন্তু a positive Mantoux means you can have to start the treatment. বাচ্চাদের তো past infection হবে না, বাচ্চাদের recent infection হবে. Okay, so that is indication. Remember the diameter for the positive Mantoux, it is more than 10, it is positive. 6 to 9 it is equivocal, less than 5 it is negative. But there is a problem. If the patient has HIV, HIV পেশেন্টদের কিন্তু এই 10 মিলিমিটার diameter আসে না, so there will be less. So interpretation with HIV is different. Okay, I am not getting into that, but remember this is for the normal immunocompetent patients. This is the IGRA, I am not getting into the steps. And we have MGIT, which is a liquid based culture, as I told, Middlebrook 7H9. MGIT we do test for the drugs. This is how the tube looks. Coming to the treatment, okay, you have these all medicines which are called anti-tubercular drugs or ATTs, anti-tubercular therapy. You have the first line agent HRZE. H means isoniazid, rifampicin, pyrazinamide and ethambutol. So these are the first line agents. মানে প্রথম সারির যে ড্রাগগুলো সেগুলো হচ্ছে HRZE. Then you have second line agents, তার মধ্যে অনেকগুলো ক্যাটাগরি আছে, ক্যাটাগরি A, B, C, D. Category A is antibiotic called fluoroquinolones, that is floxacins, ciprofloxacin, levofloxacin, moxifloxacin, levofloxacin, gatifloxacin. So these are the 3 floxacins or 3 fluoroquinolones that you have. Then you have injectables which are aminoglycoside, okay. You have amikacin, you have kanamycin, capreomycin, which are category B second line agents. You have category C, ethionamide, cycloserine, and then you have certain agents which are very new. They have been introduced in the last decade, which you find it here. These are bedaquiline and delaminid. These are the 2 new drugs for the TB, bedaquiline and delaminid. This is the treatment protocol, this is the strategy. RNTCP introduced something known as DOTS, DOTS. DOTS means directly observed treatment short course. That means whenever you are having a TB patient, you have to put the patient under supervision that they are having the medicines or not. DOTS therapy bole chhe, okay. So these are the first drug for the sensitive tuberculosis. We do start in 2 phases of treatment. One is the initial intensive phase, which is started with 4 drugs regimen HRZE, which is continued for 2 months, and then you move on to the continuation phase, which is given by HRE, which is again given for 4 months. So total they will be having 6 months of the treatment. দুটো ফেজে ভাগ করা হয়েছে কেন? The first initial intensive phase, they rapidly kill the organisms. They make the patient non-communicable in some cases. এইটা যদি ভালোভাবে পেশেন্টটা খেয়ে নিতে পারে, then the patient might be non-communicable to TB again. He might not give the infection to the other person by normal coughing and sneezing. And then you have 4 months of HRE. That is the normal drug sensitive therapy. Now what about the drug resistant therapy? Drug resistant therapy te you see this is the DSTB, drug sensitive therapy. No resistance detected, 2 months of HRZE, 4 months of HRE. But if any kind of resistance is occurring, then the whole thing changes. So many complicated, so many drugs, okay. 2 new drugs, as I said, bedaquiline and delaminid. I'll not go into the details, but they have their limitations. They cannot be given to all the patients. You cannot give a bedaquiline to a pregnant patient. You cannot give a bedaquiline to a pediatric patient. So that's a problem. You see, this is the MDR TB regimen. The first MDR means multi-drug resistant. Multi-drug resistant মানে যখন isoniazid and rifampicin দুটোই resistant থাকবে, you called MDR. Whenever you are finding MDR, see the treatment. The initial intensive phase, it is for 9 months, 4 to 9 months, and the continuation phase can extend till 18 months. 18 months means 1.5 years. And XDR means fluoroquinolone, MDR to থাকবেই থাকবে, তার সাথে fluoroquinolone and at least one of the injectable will be resistant. সেই category of resistance কে আমরা বলবো XDR. XDR is very difficult to treat, and the patient might die. So that is very, very important. Now the question is, why does the drug resistant occurs? একটা পেশেন্ট টিবির ওষুধ স্টার্ট করলো, মধ্যে গিয়ে ছেড়ে দিল, আমার আর খেতে ভালো লাগছে না, খাবার ইচ্ছে চলে গেছে, বমি পাচ্ছে, কি ওষুধ নিতে ভুলে গেল, কি অন্য জায়গায় চলে গেল, রিলোকেশন অফ দ্য পেশেন্ট. So these are the things which gives continuation therapy to break হয়ে গেল. And whenever there is a break in the continuation of therapy, there is a probability of rising drug resistance. And these drug resistance will be in the form of either MDR or XDR. MDR তো তাও ঠিক আছে, you can be treated, but XDR treatment is very, very difficult. And এগুলো যেহেতু ইনজেক্টেবলস রয়েছে, প্রত্যেকবার পেশেন্টকে ইনজেকশন নিতে হবে, সেখানে কিন্তু কমপ্লায়েন্স রেট আরও কম. So that is very difficult. We lose XDR TB, and you see MDR TB population is 6.19%. It is not so low. 6 মানে যথেষ্ট বেশি. আর MDR এর মধ্যে XDR হচ্ছে 1.3%. It is still low. Okay, so tuberculosis elimination program has been launched. The government said that we need to eradicate or end TB, WHO has said, by 2035. So that's how we are going. And India has a national strategic plan that we are visioning for, elimination of TB. The government has developed few things. They have developed an app, 99 dots bole একটা app আছে, এবং the surveillance is increased. Whenever there is a TB diagnosed, we need to upload the patient demographic data to something called as NICSHI. NICSHI বলে একটা গভর্নমেন্টের পোর্টাল আছে. যখনই একটা পেশেন্ট টিবি ডায়াগনোসিস হচ্ছে, অল ইন্ডিয়া রেজিস্ট্রেশন হয়ে যাচ্ছে নিক্সাই পোর্টালে, এবং এনি পার্টস অফ দি ওয়ার্ল্ড ইউ ক্যান ওপেন দ্য সাইট অ্যান্ড ইউ ক্যান ভিজিট টু দ্য সাইট অ্যান্ড হ্যাভ দ্য পেশেন্ট আইডি অ্যান্ড গেট দ্য ডিটেলস অফ দ্য পেশেন্ট, কি কতদিন ট্রিটমেন্ট পেয়েছে, কি পজিটিভ ছিল, অল দ্য থিংস উইল বি ডিটেলড ইন দ্য নিক্সাই পোর্টাল. ওকে, ভ্যাকসিন রয়েছে টিবির, এভরিবডি হ্যাজ টেকেন. বিসিজি এভরিবডি হ্যাজ টেকেন, নো? সবাই তো বিসিজি নিয়েছে ছোটবেলায়, তাহলে টিবি হচ্ছে কেন? ভ্যাকসিন নিলে তো টিবি হওয়ার কথা না, তাই না? ইউ হ্যাভ টেকেন এ টিটেনাস টক্সয়েড ভ্যাকসিন, তাহলে টিটেনাস হওয়ার কথা না? You have taken a BCG vaccine, then why TB is happening? It should be eliminated, no? You have a vaccine. No. BCG vaccine doesn't eliminate the probability of developing TB. It eliminates the probability of developing complications of TB. Key complication? Extrapulmonary complication. Fulminant tuberculosis, disseminated tuberculosis, meningitis. So all these things, এগুলো প্রিভেন্ট করার জন্য ইউ হ্যাভ টু টেক আ বিসিজি ভ্যাকসিন. তাও বিসিজি ভ্যাকসিনের কিন্তু এফিকেসি, ইট ইজ নট লাইফ লং. আই থিঙ্ক ইট ইজ অ্যারাউন্ড 10 to 15 years of life. So you have to take BCG vaccine at birth, and then again if it is not given at birth, you can give it up to 2 years. তারপরে আর খুব একটা মানে হয় না বিসিজি নেওয়ার. Everybody will be having a scar in the deltoid. আছে তো সবার স্কার? তোমার নেই? বিসিজি ভ্যাকসিন নাও না, you must be having a scar. Even if it is a small scar, you must be having. See, this is the scar that you will be having. See, prothome there will be a papule which will be developing into an ulcer. আলসারটা হিল হবে, ছোট একটা স্কার হবে. যদি বিসিজি ওভারডোজিং হয়ে যায় তাহলে স্কারটা বড় হয়ে যাবে. So that's a problem. Okay. Okay, another thing is we will be just brushing into non-tuberculous mycobacteria. See, this is the atypical mycobacteria, as I told. I'll directly come to the classification. It's a huge classification. Just try to understand few things. They are classified as photochromogen, scotochromogen, non-photochromogens and rapid growers. Chromogen mane ki? Color. Photochromogen means they will be producing pigments. Why are everybody looking at me? Pigment in presence of light. Scotochromogen means they will be producing pigment both in dark and light. Only thing is that light pigment intensity ta bede jabe. Non-photochromogens, no pigment. And rapid grower means they will be having growth in the media within 7 to 10 days. What kind of infection does they occur? আচ্ছা, কোথায় থাকে আগে জেনে নি. NTMs are present in the environment, in the water sources, জলে থাকে. So you might be bathing with an NTM, you don't know. US population is said to have 60% of NTM antibodies in their system. 60% of population already exposed to NTM because of the water supply. So they will be presenting in reservoirs. Reservoir থেকে তোমার বাড়ির ট্যাঙ্কে আসবে, ট্যাঙ্কের থেকে শাওয়ারে যাবে and you will be happily bathing with it. Mostly they will not cause an infection, but if they have to cause an infection, they can give rise to a cutaneous disease, which is a ulcerating disease, which can give rise to a nodule or it can give rise to a ulcer. You can have pulmonary disease similar to tuberculosis. You can have disseminated disease, multi-organs are affected. These are the photochromogens, that is their color. তার মধ্যে মেরিনাম causes swimming pool granuloma. Scotochromogens এর মধ্যে, this is very important, this is called scrofula. Scrofula means cervical lymphadenitis, which is caused by Mycobacterium scrofulaceum. Then you have non-photochromogens. This thing is called Burulli's ulcer. It is a very painless ulcer. It is a very dangerous ulcer. And you have rapid growers. They grow within 1 week. Normally TB takes to grow around 4 to 6 weeks. These are the things that grows around 1 week. So this is the whole chart you will find in the book. I have taken this from the book only. Hot tub lung means it is not an infection. Hot tub lung means repeatedly jodi keu gorom joler moddhe oi hot tub gulor moddhe snan kore, then repeated exposure of the NTMs will give rise to a ground glass opacity lung. HRCT korle dekhbe lungs er moddhe ground glass opacity hoye royeche. You will think that the patient has COVID or a kind of viral infection, but no. The patient is suffering inflammatory response or granuloma formation from the TB antigens. So that is what it is called, hot tub lung. Lab diagnosis is same. Only thing is that there is a separate PCR for NTMs. ZN stain era positive debe, and these are the things that they look like. Beaded appearance beshi thake na NTM e, and they will be not so curved, they will be more or less straight. So that is how they look. Treatment is not with the anti-tubercular drug. Treatment is with clarithromycin, and in some cases we also give ethambutol. Okay, ethambutol and clarithromycin is the drug of choice.